Good afternoon. Welcome to the European Reference Network EuroBloodNet Topic on Focus on Cutaneous Lymphoma for patient organizations. This is a collaboration with the Lymphoma Coalition, the Cutaneous Lymphoma Foundation, France Lymphoma Espoir, and Eurordis. The program aims to disseminate the innovative topics related to cutaneous lymphoma among patient organizations in order to improve capacity building and to give visibility to the medical services available in Europe. Today's session is about treatment options available in Europe, and we will be focused on skin-directed therapy and systemic therapy and clinical trials. We have very relevant voices today with us. Professor Rudolf Stadler will be presenting the clinical part, and Guy Bouquet will be in charge of the patient voice. Professor Rudolf Stadler chairs the Department of Dermatology of the Medical Center Meiden. This is a leading dermatology department in Europe and is one of the largest in Germany. He has been president of the German Society of Dermatology and the Cutaneous Lymphoma Task Force of the European Organization for Research and Treatment of Cancer. He has a vast research activity and has received several awards in recognition of his outstanding and exemplary contribution to promoting and advancing dermatology at national and international level. As I mentioned, the patient representation will be on charge of Guy Bouquet. Guy is patient expert, president and co-founder of France Lymphoma Espoir, and he's involved on an international level as a director of the Lymphoma Coalition Europe. He's also a member of the European Society for Bone Marrow Transplantation Patient Advisory Committee, and participates in several advisory boards, and it's involved in building different education programs. We also have today with us Susan Thornton. She was a promoter of this program. She's the CEO of Cutaneous Lymphoma Foundation and has a personal experience with cutaneous lymphoma. And I want also to say thank you to Ariane Weinman, the Eurordis Public Affairs Senior Manager. She supports the European patient groups advocacy in the 4 European reference networks, including EuroBloodNet. So without losing more time in this, I will give the floor to Professor Rudolf to start his presentation. Welcome, everybody.
Yeah, welcome everybody to you, everybody. Thanks for this exceptional introduction. It's an honor to me to talk to you, to the patient foundation, and so it's important to have a close connection between patients and physicians to increase our knowledge and most important to get the future perspectives in cutaneous lymphoma so that we can finally cure patients of cutaneous T-cell lymphoma. And I have to thank EuroBloodNet that this is now our topic today. So cutaneous lymphoma, new therapeutic developments is my presentation, and this is my conflict of interest. It's all companies who are involved in clinical research and studies of CTCL. So the agenda is basic therapeutic concepts, new therapeutics, and the future directions. The agenda and the learning objectives today is the therapeutic concepts, new therapeutics, future directions. And what are the key concepts? First of all, early stage mycosis fungoides should be treated with skin-directed therapy. And mycosis fungoides starts with limited disease in general, with some exceptions. So the basic motion is to keep cutaneous T-cell lymphoma in an early stage of the disease. There are also periods where you can have expectant therapy when no treatment is preferred. In advanced stage mycosis fungoides or Sézary syndrome, systemic treatments may be considered as first-line therapy. And of course, there are also patients in middle-aged with advanced stage disease, and this is the most problematic patient group. They then we have to discuss the reduced allogeneic hematopoietic stem cells transplantation to maybe cure these patients, but of course this is a hard decision because a number of patients will die by this kind of treatment approach. And finally, a holistic approach to patient care with consideration of health-related quality of life is essential, and symptomatic relief of pain, itch, insomnia, and depression may be needed. And by our international ProClippi study, we will also address these questions. What we know from the past is some basic principles to avoid cytotoxic therapies as long as possible. It has been shown that highly aggressive therapy or multi-chemotherapy will not prolong the life of the affected patients. And give skin care with emollients, reducing bacterial colonization, most important. I will come later on that. Treat additional symptoms, pruritus, especially in patients with Sézary syndrome. Use standard treatments correctly, PUVA, photochemotherapy, and systemic therapies, and think about maintenance therapy, one important issue. And what is for me and my experience over all these years, keep in close contact with your physician, because if something pops up, then immediately get in contact with them to clear the skin. That's my notion to that. The treatment strategy still in this decade is stage dependent on the stage of the disease. So from mycosis fungoides stage 1 to Sézary syndrome, or including viscera involvement, it's all stage adapted. And we start with skin-directed therapies all over decades with potent topical steroids, with narrow band UVB, photochemotherapy. And what is new, at least in Europe, and especially in Germany, is to use the alkaline chlormetine gel. The others, especially bexarotene gel, made it never to Europe. It's still available in US and Canada. And all these approaches has the idea to avoid progression of the disease. And if we talk about skin-directed treatment responsible in topical therapies, then you can see on the right the response rates in all these controlled studies. These were controlled, randomized studies with a huge number of patients in early disease stage. And as you can see, the solution compared to the gel was not inferior. And so this compound was approved worldwide, not only in the US, also in Europe, for the treatment, specific treatment with alkalines of early stage disease, and as combination part in patients with advanced disease, which have not only tumors, which have in addition patches or plaques. So both together means a tremendous advantage in this kind of therapy for these patients. And we ourselves have done a cohort study in patients in 2 German skin lymphoma centers with Ulrike Wehkamp and myself to show that also in daily practice, it's chlormetine gel, Ledaga, is of great help in the treatment of CTCL patients. And what are the current systemic treatments in advanced mycosis fungoides and Sézary syndromes? We have the immunomodulators, the non-toxic compounds, which are the rexinoids. This is example is the bexarotene with the trade name tagretine, the retinoids, the acitretin, and the interferon. Interferon is now stopped and withdrawn from the international market. Several companies did that, including Roche. So we have now worldwide the pegylated form of interferon available, and we can use it in a microgram dose once per week to replace the former interferon widely used worldwide in the treatment of cutaneous T-cell lymphoma. And in addition, we have extracorporeal photopheresis, which has shown to be potent over more than 30 years with no major side effects, very good handling, and which can be used as basic therapy and in patients with erythrodermic NF, and of course also in combination with the immunomodulators. In recent years, radiotherapy advanced a lot. It could be shown that low-dose radiotherapy is enough to control the disease, especially with total skin electron beam therapy. One has not only one single shot, one can do it twice, or in special cases twice. And then we are coming to the antibody-based therapeutics, which I will discuss in detail, and the HDAC inhibitors, which we are looking as maintenance therapeutic worldwide, and of course single agent chemotherapy, which one of the most used compounds is gemcitabine, then the polychemo and the allogeneic stem cell transplantation. What is very important is the holistic approach. And I told you that bacteria can drive the disease. Exotoxins of Staphylococcus aureus will stimulate interleukin-2 production and thereby increasing T cells, and modulate the cytokine profile to an immunosuppressive status, so that even more interleukin-10, which is immunosuppressive acting, tends to even more shift the patient into immunosuppressive. And Lindahl and co-workers have nicely shown that by using a cocktail, cutaneous T-cell lymphoma can be controlled and resolved, and then continue with other kinds of therapies. Coming to the antibody-based therapies, this has very much advanced our field by addressing certain epitopes on T cells, like CD30, CD52, which is expressed almost on all blood cells. The chemokine receptor T cell is expressed on skin homing T cells, and KIR DL2, the KIR antibody, and is expressed on, belongs to a immunoglobulin-like family, and is expressed of NK cells and transformed MF cells, and especially in Sézary cells. So these are markers which are important to be addressed, and also T-cell activation markers like PD-L1. The others I won't discuss in this presentation. So what is now approved worldwide is three compounds. This is brentuximab vedotin, mogamulizumab, and for third-line therapy, alemtuzumab. Brentuximab was proven in a huge study, phase 3 study, worldwide performed, the so-called Alcanza study, comparison of brentuximab to a physician's choice. And it could be shown over now 3 years that almost 55% reached the primary intention of treat population, the overall response rate lasting more than 4 months. And this was highly significant against physician choice. But what was the most important is that the progression-free survival lasted almost 17 months, which we have never seen with any other kind of treatment in the past. And here you see this survival, not the survival curve, the probability of PFS, and the red line, the ones which were centered and belonged to the brentuximab vedotin treatment group. And for example, this is a patient which we treated very early, where the drug was not approved, only approved for second-line therapy in Hodgkin's disease. Then we used brentuximab vedotin. These red bars are the columns, are the cycles. And here you can see the tremendous involvement here of the leg of this patient with CTCL. And this drug is given every 3 weeks. And then we increase the cycles, and he's now still a couple of years later free of disease. And besides that, besides clinical studies, there is a real world. And my dear colleague Julia Scarisbrick, head of the Birmingham Lymphoma Center, she did a case study on CD30 positive cutaneous T-cell lymphoma, and she could show and prove that all these patients showed major either complete responses or partial response, or at least stable disease, and in some depending on the grade of CD30 expression. And what we know today from extensive further research is also patients with large cell transformation will benefit from this drug, even patients with low numbers of CD30 positivity. And to increase the PFS, one can combine this drug with skin-directed therapies, where what we did, we either lowered the dose of brentuximab to 1.2 milligram every 3 weeks, and when we saw progressive disease, then we added skin-directed therapies, and we could increase partial remission and stable disease without increasing toxicity. The other important antibody is mogamulizumab, a humanized anti-CCR antibody with a difficulated FC region. This, as you know, CCR4, as I told you, is expressed on homing T cells, and also in circulating T cells, and on so-called tracks, the regulatory T cells. And mogamulizumab induces towards the malignant C cell antibody-dependent cytotoxicity, so to destroy, and it's also a double hit by addressing these regulatory T cells. And this big study, it was a huge study with 186 patients, the so-called Maverick study, and you see that especially patients benefit from it with Sézary syndrome, with the leukemic variant of MF, and also this patient cohort showed a highly long-standing duration, which lasts for Sézary syndrome patients over 17 months. The drug is applied by infusions weekly in the first month, and then twice a month on day 1 and 15 following a 28-day cycle. And here the PFS compared to the Vorinostat shows the priority of this compound gegenüber HDAC inhibitors. And here, for example, Sézary patients with which is under therapy with mogamulizumab, And what is, besides that he's off erythroderma, what is mostly bothering these patients is an enormous pruritus. And this is gone after 2-3 cycles. They don't have any symptoms anymore, which reduce their life quality a lot. And another effect is of mogamulizumab, because the tracks are addressed, the T-cell regulatory cells, that autoimmunity can be induced. And this autoimmunity is somehow beneficial for the patients. So these induce cytotoxic T cells, and which kill the malignant ones. And so there were 2 patients which are free of disease, and which was reported by Martine Bargot from Paris. So these are exceptional results. And one other big point is, how can we maintain the achievements with this modern kind of therapies? That led us to maintenance therapy in patients with mycosis fungoides or Sézary syndrome. So this is a really neglected topic. Nobody focused in recent years on that. Can I do maintenance therapy by PUVA therapy or narrowband UVB or bexarotene or whatever? And we started a study with resminostat, which is an HDAC inhibitor, and introducing worldwide in a controlled study. And this concept of maintenance therapy is according also to the stage that you get these patients in 2B, from 2B back. Of course, you can't recalculate them into stage B, but clinically, they don't have any tumors anymore. And then the question is how to maintain the non-tumoral stage. And then the patient has to be treated and not only be observed. And that is the key question we kind to address with this study. And this study is a phase 2 study with 190 patients worldwide in more than 50 centers and treated with this HDAC inhibitor orally over day 1 to 5, and then in a 2 weeks cycle. So we hope that we can present you. We have almost finished the study. We have 180 patients now, and we are still 10 missing. So we hope that we can get these 10 patients randomized in this trial, and then give you the data next year. So what are the new therapeutic developments done by the EORTC CLTF group? And this is our agenda, studies which are already closed, or and others which are upcoming in this year. So the one which is completed was the so-called PARC study, the phase 2 trial of atezolizumab in the treatment of stage 2B mycosis fungoides and Sézary syndrome in relapsed refractory stage of the disease after at least 1 previous systemic therapy. And the primary objective was to determine the anti-tumor activity of atezolizumab in these patients cohort, and this assessed in terms of the overall response rate. And this study is also combined with translational research. These results of this study will be presented by myself at the October meeting of the EORTC CLTF in Marseille, organized by Professor Bargot from Paris. And the upcoming one is one study which is called REACH. You can follow these studies by clinicaltrials.gov. You can read the whole text and in more detail than I can present it to you in this lecture. The aim is to study and determine the etiology of chromatin gel-induced skin drug reaction in early stage mycosis fungoides for cutaneous T-cell lymphoma, and to determine the primary objectives, the activity of the drug as measured by response rate in patients, Treated with this chromatin gel without drug reactions, we will have 3 groups, and which will have no reaction. Ones who have reaction, when we will lower the application rate, and the 3rd group who have severe reaction, then we will skin testing and go in more detail what is the reason for this skin irritation or allergic contact dermatitis, and besides that we do translational research. And the other trial is the so-called 1820 MOGAT trial, also sponsored by the EuroRDis. It's an open label phase 2 multicenter study of this anti-CCR4 monoclonal antibody plus total skin electron beam therapy in patients with stage 1B, 2B cutaneous T-cell lymphoma, and to evaluate the progression-free survival rate at 48 weeks in combination with this CCR4 monoclonal antibody and TSEB. And also this study is combined with translational research. How are the future directions? In the last 10 years, a number of important papers came out to show where our mutational load is located in which signaling pathways. The information from the outside to the cell goes through a number of molecules which can be mutated. And so far, we did not succeed in finding one major mutation. Like in melanoma, we can address BRAF in 40 to 50% of the patients. This is not the case in cutaneous T-cell lymphoma. It's much more hard work. And then to look for any mutation in these patients, and then to ask the question, do we have molecules in which we are able to stop this signaling pathway, which the patient could be benefit. And one study closed with the D-methyl fumarate in Sézary syndrome and MF, which inhibits the NF-kappa B pathway. So we will see what is coming out on this phase 2 study. And the other ones, the antibody molecules, I discussed with you. And the ones which is now in the phase 2 study is an important one, is in a development out of Europe, out of France. This EPH 4102 is now called lacutamab, is the first in-class anti-KIR-DL2 monoclonal antibody, and has been shown in this phase 1 trial to have an excellent response rate in this early phase 1 trial, and an excellent side effect profile. And now this study is brought into a phase 2/1, which is performed in Europe and also in the US. And I think next year, end of next year, we will have some more data about the potential role of this lacutamab, this KIR-DL2 monoclonal antibody. And the other one is the ones with addressing the PD-1, PD-L2 TL1 axis. And what we have seen is yin-yang in so form that we have patients who benefit excellently and others who progress tremendously. But in the moment, we have not the right idea and the right molecule identified. There might be one which gives us a hint which patient would benefit from PD-1 or PD-L1 therapy. But this we will answer, I think, I'm sure, in the next couple of years. So what is summarizing what I've told you is, and what are the take-home message, is that still today, stage-adapted therapy is of utmost important, and this in close contact with the patient. There is no gold standard, but there is a number of ways to do it wrong. So this should be known and is a major strategy. Second, these antibodies I showed you, these antibody-based therapies, improved CTCL therapy in recent years. And with this, we can, in combining these new compounds, we may advance the field and patients will benefit from that. And then on the third point, maintenance therapy as an important concept to keep the patient at least with minor involvement of the skin or totally clear. But since we do not have any cure, so maintenance therapy is of utmost importance. And then I told you that the antibiotic therapy and the bacterial exotoxins drive the malignant process. So there must be a holistic approach to patient care. Besides antibiotic therapy, decrease the colonization of bacteria on the skin, and besides that, treat pruritus and pain and everything what bothers these terrified patients. And of course, we have to work hard to design new clinical studies and do basic translational research to improve the field in the near future. So thank you very much for your attention.
Thank you, Professor Stadler. And I think that is such a wonderful presentation to show everyone what's been happening really relatively recently in new therapies for cutaneous lymphoma patients, all of the research that's been going on behind the scenes to understand the complexity of this disease. There's no one easy answer. And I think the terminology is, if you've seen one patient, you've seen one patient. And we've got a lot of work to do to figure out how to create these newer therapies to target the right patient at the right time, wherever they may be in their disease journey, right? So, but I think from a patient perspective, it's so exciting to know that all this work is being done and so much more to learn, but we've really made some great progress in the last 5 to 10 years that has been unprecedented. So, and more to come, which is really exciting. So thank you very much. And I think that sets up our next guest speaker, my wonderful colleague and dear friend, Guy Bouguet, who comes to us from France and the French Lymphoma Organization. And really, Guy, the importance of patient advocacy and why, as those of us that are patients and are kind of immersed in making the connections with the clinical community and the regulatory community, and how that's so important, the role that this patient advocacy plays to bring these new therapies to the table, but also to feed back what the real patient experience is. So I will turn it over to you to share a little bit about your experience and what you've been doing in the arena of patient advocacy, not only in France, but really globally and throughout Europe. So the floor is yours.
Thank you, Susan. I also wanted to start by this comment. As Professor Stadler was speaking, I realized how tremendous the advances in treating cutaneous lymphoma were made in the last 5 to 10 years. I mean, as far as quality of life, with the appearance of this gel that is now helping people to have a better quality of life, but all those new molecules, those antibodies, and we see that there's new one coming up. So it is just really, it is just amazing what's happening. But I know it is an area where there was a lot of unmet needs, and it is important that the industry and the researcher focus on this side of science. Regarding, you mentioned that I have some type of an history with the disease. Well, I don't have specifically an history with cutaneous lymphoma. I was diagnosed with follicular lymphoma, which is a a more systemic type of lymphoma, one of the most common type of indolent lymphoma. But what I can share with some of the cutaneous patients is two things. The one thing is the fact that the indolent form of lymphoma I had was a recurring type of lymphoma. It's a lymphoma type that basically relapse every so often. For some people, it does not relapse, for a very long time. For me, I felt like, yeah, it is very similar to what some of cutaneous lymphoma patient can experience, which is a relapsing period that is very short, and basically having to increase into the treatments potential and treatments availability. And at the end, what actually I can share as well with some of the patients is the fact that I had to go through a allogeneic bone marrow transplant, and going through that process, as Professor Stadler say, I mean, it's a very, I would say, very specific steps into the treatment of lymphoma. We know it does work, but sometimes it doesn't work, and we don't know why it doesn't work. But when it works, it's miraculous when it does work. When basically the bone marrow transplant, the marrow or the immune system you receive from your donor actually managed to keep the disease in control, and that's amazing. But like every other treatment, there could be topic treatments, there could be intravenous treatment, they could be antibodies or CAR T cell. There are always side effects. And for bone marrow transplant, allogeneic transplant, there could be some serious side effect. It is not a rejection of the graft, but it is basically developing some autoimmune diseases, which basically put the patient into a different type of medicine. Like I've been grafted 16 years ago, but I don't see my hematologist anymore. For the last 16 years, I'm seeing a transplant doctor, which is a completely different science. And the science of the graft doctor is to basically make sure that those immune systems, they can co-live together. Anyway, so this is what I can share with some of the cutaneous patients as far as my experience. But as far as the work that I'm doing every day, after I was diagnosed for follicular lymphoma, I realized that there was not enough information. It's basically the usual process of understanding what's around for patients, how our patients can make a wise decision on their treatment, how can they understand their treatment. So I realized that was in 2000, there was no information. So I co-founded an organization called Lymphoma Espoir in 2006. As a matter of fact, the day I created this structure, I went to the meeting room inside the hospital with my, I don't know how you call it in English. Basically, I was still connected to my IV. I had just received my bone marrow transplant a couple of weeks before that. So the idea behind the patient organization is basically it's to provide information, educate patients, so that we do have patients that, as I say, understand what's happening to them, and they can make the proper decision, have the proper discussion, and evaluate the treatment with their doctors. So the mission is information. It's also providing support to the patients that go through the disease by different type of means. It could be meetings, it could be platforms, it could be anything like this. And it's also the care that we provide this information and the support for. And of course, at one point, it is to support research, and in the way we can try to stimulate the research. And of course, and that came with time for us, because when you start, you're very small, you depend on some sponsors, and then as you stay alive as an organization, you do creative work, you become more let's say an actor into the system, you are a validated actor. We engaged into advocacy, and this is where, well, Susan and I and Natasha, we've been doing quite some work together at the international level, but also at the national level. It is basically being able to represent the patient in front of the authorities and the regulators. It is telling them that, you know, they're making the wrong choice, they're making the wrong decision, and really fight for the patients. I'm very lucky also, I didn't mention that, but my organization is located in the same hospital as Martine Bagot, and Professor Stadler mentioned her quite a bit. And Professor Bagot is at the source of many research that were highlighted earlier today. And so I have the chance to talk to her and get some insight from her. And over the last, I say 18 months, we've been doing quite some work on this mogamulizumab treatment, because it was going to be first approved in Europe through the French. France was going to be the first country to approve the disease and actually negotiate the price for the molecule. And over the last 18 months, we had to struggle quite a bit. And recently, we managed to basically allow this treatment to be prescribed, to be infused at home, which is a very big improvement, especially during the pandemic pandemic time. We were able to fight for reimbursement and making sure that the molecule was completely reimbursed wherever the patient was treated in France. So that access to everyone was a major work. So again, yes, we're doing a lot of work with Martine Bagot, and Martine Bagot she's never, let's say, in need of. She always had good ideas into developing new therapies and new trials. As I said earlier, we do work, Natasha, Susan and I, through different type of networks, through also the ERN network. We do collaborative work together. We are part of different groups like international collaborative organization like the Lymphoma Coalition. We do participate into the EBMT, EHA. We try to we try to influence also the decision makers, but the people who actually do the treatments and provide treatments. But we also share our own experience. And for instance, with the Cutaneous Lymphoma Foundation, I've been working with Susan for many years. And the first step of our collaboration was to basically create a brochure for the French patients. And we used the model of the coalition for the Cutaneous Lymphoma Foundation. We used that as a baseline for the development of our brochure, and we of course adapted it to the French system. And it was key to have someone like Susan, because over the years we had also, as a patient organization, neglected those rare lymphomas, and if it hadn't been for Susan, I don't think we would have done it as fast as we've done it. And it is today, I must say that the brochure, the document that we created, is extremely well perceived and used by patients and doctors.
And I think you bring up a really good point, Guy, when you, especially for the rarer diseases, how important it is for all of us on the patient advocacy side to work together and collaborate, because none of us can do the work on our own. For us in the Cutaneous Lymphoma Foundation world, understand the disease very well. We understand the patient experience, and we are very fortunate to be invited to the scientific meetings to learn about what's happening in research and clinical trials and connecting. But, we're small, there's only 5 of us. So trying to be expert in what's happening in France or what's happening in Spain or other locations is really hard. And of course, we don't speak the language, so that makes it even more difficult. So these collaborations are so critical to bringing the information to the patients and really bridging that kind of that gap between, what happens in the clinic with the patients and then what happens when they go home, and then they have all these questions and how do they manage that, and then bringing that information back again into the whole process. And I think with all of the new therapies that are becoming available, the challenge now is how do we make sure that while they may be approved on the clinical side, that they actually are available for patients under the different health systems and the access and the reimbursement. And that really requires a lot of collaborative effort and data collection, which is where the independent patient perspective comes into play. And we have to all work together to be able to present that kind of united front, right? To make sure that at the end of the day, all the patients have access to not only the therapies, but the specialty physicians, and how do they know who they are and where do they get them? So it's, we all have to work together. And I think that's what makes this all fabulous and very exciting to be able to get to this point. And it's been a great, I think, our collaboration over the many years, as we've kind of done it, not really super formally, but has made a big impact. And now we have this great opportunity to co-host with Martine Bagot, kind of our first formal patient program after the finish of the scientific meeting in Marseille. So that will be so exciting. And I think that's a culmination of many years of
absolutely effort. I had noted that we need, it's on October 16th for people who are interested. It will be in Marseille. There will be the first patient session at EORTC.
Yes, and all delivered in French, except for me.
And in English, if we have enough English speakers, we'll have the translation.
Yeah, that's great.
I just want to quickly finish what I was going to do. Talk about. I mean, patient support here. You have like the brochure that we've done, but I want to cover some of the challenges because we've done a survey to identify what were specific challenges for those rare types of lymphoma, and we measured Hodgkin lymphoma for young adults, and we measured as well cutaneous lymphoma, and it is a really a disease of its own, of course, and they are also added to the fact that there are so many different subtypes of cutaneous lymphoma that don't get the same type of treatments. But the most challenging part is knowledge of the disease. It's the knowledge of the disease from the patients, and still and some of the medical professionals. Some of them, the diagnosis process can take. It does take a long time for other bigger type of lymphoma. It can take months sometimes, but for cutaneous lymphoma, it could be extremely long, and it is extremely frustrating. It can take years. Is cutaneous lymphoma treated by hematologist or by dermatologist? That sometimes is a real problem, because the patient get bounced back from one specialist to another, and sometimes, yes, some expert center are very lucky to have put a system in place to care for this, but in other places it's difficult. Is there a cure, really? Is there a real cure for some type of cutaneous lymphoma? That's a question. Treatment options and burden of the disease. Of course, the burden of the disease, it is one of the type of lymphoma that is actually visible, and it could be a real challenge in a society that when you show your differences. And the last thing is clinical trials, and clinical trials is very important, and we see that the activity is growing as well. And just an example is we put together a website in France, a platform where the French patient can go and look and find out if there is a clinical trial in France that is open, phase 2 or phase 3, that addresses their subtype of lymphoma, and we give them all the information in a comprehensive language, of course, in French, for those who speak French, and also we refer them to the hospital where those trials are open. So this is part of informing and giving the tools to the patients so that they can take care of themselves as well in a very difficult journey sometimes.
Great.
I don't know if you want to take the questions now.
Yeah.
Before you, may I just interrupt?
Please go.
And
Yes.
Susan and Guy, if I can address you like this, I would thank you for this tremendous engagement. I think this is not only important for the physicians, for the patients, and also for the physicians, because dealing with cutaneous T-cell lymphoma, and I see a dear friend of mine, which is also following, is Robert Knobler. He's a pioneer of photophoresis in Europe and also all over the world. So this you have to have passion for these patients. And Guy, you asked the question, hematology or dermatology. It's not the question either hematology or dermatology. I think we have to have cooperations, and the hematologists have different ideas than we from the dermatology part. And you see, the hematologists were much more aggressive by history than we did. And so the combination might be a benefit lastly for the patient. And what you achieved in France, we have to put that, as you mentioned, all over Europe. And to get in touch, maybe we can address the representatives of each country in Marseille under the guidance of you and of Martin, a dear friend, which does, as you said, exceptional work on CTCL. And as you see, the Hôpital Saint-Louis has the tradition of cutaneous lymphoma worldwide. So we hope we can come together, and also our national health systems has to come together, because it can't be that that a patient in France can get mogamulizumab at home, and in other countries only in the hospital, or even if he can get it. So this we have to overcome. So, but this is a nice achievement what you did for your patients in your country, and I think this is exceptional. Thank you so much.
Totally agree. And I think what's so exciting is that we're on the edge now with the visibility of the disease, and being able to do a program like this to bring people together and visibility. And it's a new future for all of us, which is really fabulous, really fabulous. So thank you. Okay, we had a couple of questions. There was a question earlier in your presentation, Professor Stadler, about what does it mean when you talk about clinical trials and physician's choice, within the clinical trial arm? Oh, you're on mute. Unmute.
Excuse me.
Professor, there you go.
The physician's choice is either a standard kind of therapy, what we did in the past, like methotrexate was a comparator in the brentuximab vedotin study, or an HDAC inhibitor, which was approved in the United States, not in Europe. So these are the comparators as physician's choice.
Right. So it gets complicated, especially in a rare disease, when not all the treatments that may be available are actually available in the country that is conducting the clinical trial. So it gets even more challenging.
That's
But
right.
yes, which hopefully will be in the future, that won't be the case, but we shall see.
In spite of the fact we are living either in the US or in Europe or elsewhere, our dear colleague Pietro Quaglino is the head of the lymphoma unit in Italy. He has shown through the ProClippi study that patients, whatever we do in the United States or in Europe, have the same prognostic index. So we don't have any secret bullets in either continent, neither in US nor in Australia. So we are basically doing what I showed you. But the skill is to combine it correctly and use it timely. That's a secret in handling lymphoma patients.
Right, right. And again, why it's so important for patients to understand some of these components of so that they can participate, because without the patients participating, you can't gather the data, and we need to feed back, well, what is our experience? How did this work? Was this available? Would a home infusion be a good option? Would that be, so you've got to collect all of that information and put it together for the best possible way to treat and share it amongst all the clinicians worldwide. Anyway, I'll get off my soapbox. Someone asked, is there a foundation in Belgium? Not yet, but there is one in the Netherlands, which is right next door. And our friends Mickey and Tan are here on the webinar. And one of our goals is to connect with patients in the different countries. If there isn't an organization, because it's such a small rare disease, it takes a lot of effort, like Guy shared, to not only create a foundation, and I think Mickey and Tan can probably speak to this because they've just done this recently, but then to maintain it over a long period of time and to be able to deliver the information and to have the technology to do it requires a lot of effort and some money, actually. So, the goal is really to connect everybody and to leverage our colleagues from other bigger lymphoma groups like Guy's and plug in the cutaneous components kind of underneath within the country. So, we're starting, but we're happy to help you in any way and connect you into the larger cutaneous lymphoma community. So feel free to reach out to myself or to Guy or to Mickey and Tan. And I'll put my my email here in the chat so that you can reach out, and happy to happy to help, because I think the important thing is to connect the patients together, however we may do that, through all different methodologies. Let's see, and I know we had a question with regards to the impact of stress on the disease. So I don't know, Professor Stadler, that this question gets asked quite a lot. And I think we have a lot of anecdotal information, but no one's really looking at the scientific data to see if there's any impact.
This is a part of a future project of the ProClippy study of quality of life to measure that. So we don't have really correct data. But anyhow, in general speaking, stress in every situation of cancer is not a good idea, not a good advice. So any physician should try to get the burden of the disease from the patient and give him hope and give him clear recommendations. And this is I think most important. Personality of the physician, strong arguments, not jumping from one argument to another, keep the line, what you are doing, what you are saying, what you are diagnosing, and what kind of therapy you are. And be open to call another colleague for a second opinion or third opinion, whatever. And that will, then the patient will benefit and will trustful in the university, hospital, or elsewhere, and of course in the leading physician.
Yes. Yes, absolutely. And I'll also jump in to say that through the Lymphoma Coalition, we do a global patient survey around the world every 2 years directly to the patients. And in the last global patient survey, we had over 500 cutaneous lymphoma patients and caregivers. So we were able to pull that data out, and it's data specifically from the patient experience, which adds that part in a data format into the mix. And we'll be launching the 2022 survey early next year, and hopefully we can engage all the physicians to share that with their patients to get more responses. And the more responses from around the world, we'll be able to slice and dice the data by geography, by the different diseases, and we're adding an additional 5 specific questions for cutaneous lymphoma patients, asking more about, the impact of on their to what Guy had mentioned, the physicality of the disease and how does that impact their quality of life, and some questions around, sleep, and diving a little bit deeper. And then from there, we can do more and add back into the Proclippi. So the Proclippi, Professor Stadler, do you want to talk? Can you share a little bit about what Proclippi is? Because I know no one on the
Okay. Yes, that's a coalition of the International Society of Cutaneous Lymphoma with the European Cutaneous Lymphoma Group, and which was founded together with the leading female persons, Young Kim and Julia Scarisbrick. And the opening meeting we had in Stanford years ago. And then we divided the part of early disease development and how many patients will advance per year to advanced stage of disease. This gave us the first real life data that we can judge about 5–6% of the patient will go into another stage of the disease. And our US colleagues are focusing on advanced disease. Then we ask the question, how many delay is associated with cutaneous T-cell lymphoma diagnosis? But as Guy mentioned, I think we made major advances, at least in the last years, in diagnosing cutaneous T-cell lymphoma. We advanced the field in blood criteria and involvement, especially from the Leiden group, Martin van Meer and Van Dongen. We have now a network, EuroBlood network, and we will start a study with new antibody cocktails just to objectively diagnose Sézary syndrome, not depending on any subjective notion of any physician. So I think this will advance the field. And together with your foundation, we have to make a map. Where are the centers for orphan disease? Where are the experts? And then on the countryside, we also have to identify physicians who are interested in this disease. If you don't have any physician who are interested in the disease, forget it. So this has to be compassion, and this is a key issue.
Yes, a lot of work to do. We'll be circling back to you for all of that so we can update our European center listing. Yeah. We just finished updating the US list, so on the website. So I'll get your help for that. Yeah. I know Guy had to jump off, so we want to just thank him for his time and efforts. And he's been such a wonderful proponent for cutaneous lymphoma patients in France. It's been delightful to work with him. I know we're finished a time. We did have one very clinical question. If you have another moment, Professor Stadler. It sounds like a patient that is trying to determine, it sounds like a Sézary patient, and did okay for the first cycles of treatment. The Sézary counts went down, but they're trying to figure out, I guess, with their physicians, when are the counts low enough that you modify, like you were talking about, right? The maintenance.
Yes, you got the question quite right. And this, I was shown the total number of T cell counts. This is not the criteria. We are far further in the development. So we have special criteria. These are CD4 positive, CD26 negative T cells, or CD4, CD7 negative T cells. These are the major characteristics. And this has to be followed. And these are the parameters to classify B1, B0, B1, B2. And then you do FACS analysis. And this has to be done, let's say, every other eight weeks or 12 weeks. And then you see the decline. If the patient had B2, as in Sézary syndrome, he had to, by definition, then you can control objectively the part of CD4, CD26 negative T cells. But you have to have a FACS analysis to have this objective parameter. And then you can, this is an important question, then you can extend the cycles of mogamulizumab and see what is the individual dose to keep this patient free of disease or clear mostly.
Right, so it's the combination, some very important things I think that you raised. It's important for patients to be seen, especially with more complicated subtypes, to be seen with experts in the field. So you need to be at an expert center, and they need to have the right tools for making sure they can actually understand what's happening in the biology, in addition to seeing what's happening physically on the skin, and then having those conversations with the patient and an expert physician with the data to determine how the treatment should be done going forward, and then to be monitored very closely, because we just don't have that many patients, and we've got these new therapies. So we're learning as well, and it really needs to be individualized. So thank you. I think it's so critical for patients to find their way to the expert centers, even if it's just for a one-time second opinion. And, you know, I know everyone that I know on the clinical side is so willing and wonderful to work with other community physicians and so forth and serve as consults, because not all patients can physically travel all the time to the major centers. So you are all fabulously generous and willing and able to collaborate with other clinicians. So I think that's really important. Let's see, I think, and I know we're already 15 minutes beyond, and Guy, you're back. Oh, okay, we have one more question. Diagnosed with MF 30 years ago, still doing fine, good. Faher, using diprosine for skin lesion and wondering about the best treatment. Well, I always think it's good to talk to your physician, and I'm not familiar with that topical. It might be a steroid.
What was the name? I didn't get it.
Diproxene, Diprosene.
Diproxene. That means it's a steroid.
Sounds like a steroid, right?
That's a steroid. Okay, you know, steroids, you can use it to, which is anti-inflammatory, but it's non-specific for cutaneous T-cell lymphoma. And if you take it too long, you harm your skin. You have a tremendous atrophy, telangiectasia, whatever side effect in steroids induce. So I think nowadays we have far better skin-directed therapies than to use high-potent steroids over a longer time.
Yeah. So it would be great to talk with your physician, and if your physician would be, if they're not a cutaneous lymphoma expert and they may not be aware of some of the newer availability of like Ladaga and some of the other treatments, then I'm sure Professor Stadler or any of the other physicians, depending upon where you are in Europe, would be happy to consult, you know, and share and make sure that, you know, your physician is aware. So yeah, I think that's it. So much to take in, you know, it's like everybody's head explodes. I know it's hard. I've been doing the deep dive with all the wonderful scientists and researchers for 11 years, and it's still a lot to kind of wrap your head around. But I think that's why we're all here from the patient organization side, is to kind of do that translation and put that together in layman's terms. And again, it's so wonderful to be welcomed and invited into the clinical community with such open arms, because that really makes a difference, you know, and bringing that information forward to the patient. So thank you so much, Professor Stadler and Guy. Always a pleasure. And we'll gather in Marseille for more dialogue.
Hopefully, yes, we'll see.
Maybe we can find a way to get Nikki to come, Nikki and Tan.